phenomenon is known as CT to body divergence. And there's many contributing factors for that. But one of the main aspects is that the pre-planning CT scan is done at completely different volumes. And those of you who've gone through a CT scan know about this, particularly with a chest CT scan. You'll lay on, depending on the type of scan that you're getting, you lay on your back, you put your arms up, and then a robotic voice will go off in the CT scanner and it'll say, please take a deep breath and hold it. So ideally, everybody's CT scan should be done at full inspiration or total lung capacity, or TLC, right at this top right here at this peak. But the reality is people are people, and they're not going to be able to take their breath right and hold it right at total lung capacity. So usually, pre-procedural CT scans are performed somewhere in the inspiratory reserve volume. But when you're actually performing the procedure, you're probably doing it at tidal volume. And so you're way down here in this red circle. But if you have any post-intubation atelectasis, you may be down in the expiratory reserve volume. So your scan may have been done here somewhere near the top of the total lung capacity in the inspiratory reserve volume. But in reality, you're performing your bronchoscopy at the expiratory reserve volume. And so why does that happen? So there's a lot of reasons why it happens. But CT to body divergence is something that we all understand when we take into account respiratory motion. This is from Hans Lee from a Veritas study that looked at respiratory motion throughout for peripheral lung nodules. And we all know that up at the top of the lungs, you're going to see, hold on, let me go backwards. At the top of the lungs, you'll see that the upper lobes, there's not a whole lot of movement, typically around a centimeter or 1.2 centimeters. And these are median numbers for approximately 84 patients. And then if you look in the lower lobes, because of the motion of the diaphragm, there's up to 2.5 centimeters of motion, and sometimes up to 4 to 5 centimeters of motion, depending on the particular patient in this particular study. So that's a lot of variation, and so that creates problems for us when we're trying to go after small peripheral targets. Other changes that can lead to CT to body divergence are extra pulmonary, and so things like pleural effusions. You can see here that this peripheral lung nodule target is moved significantly when there's a pleural effusion layering out underneath the posterior aspect of the lung, and makes it very difficult for us to know exactly if we're in the right position. And this is something that can happen in between the time of the pre-procedural scan and the time that the patient is at the on the table. One of the other things that's really important to understand is that as soon as you intubate a patient and time goes on, there is a potential for atelectasis to occur, or post-intubation atelectasis to occur. This is from one of Dr. Pritchett's patients in Pinehurst, North Carolina, where there's a pre-procedural scan, they get intubated, you can see some significant changes. There's dependent atelectasis, pleural effusion, and those findings are worsening over time at the end of the procedure. And this is one of my patients, and this is something that will really drive home the point when we're talking about CT to body divergence and changes in the lung after intubation. So this is actually two different patients, and this is taking into account specific ventilation protocols to help mitigate the issues associated with CT to body divergence. These are patients with both left upper lobe lung nodules, and what you'll notice on the patient and over here in panel A is that there is significant subsegmental atelectasis that completely changed the lung volumes. And then you can even have such significant atelectasis that you could actually obscure the lesion and you won't be able to see it or visualize it no matter what platform you have. And there's other findings that are also very interesting. You can see in this image, the diaphragm is very high. So prior to instituting a specific ventilation protocol, we noticed when I was placing patients on breath holds that the diaphragm would fly up because I was going from PEEP of 5 or 6 or 10 all the way to ZEEP or 0 PEEP, and then you'd see the diaphragm fly up. And so it makes your bronchoscopy and the CT to body divergence significantly worse. So these are all issues that we're having to focus in on, whether it's specific ventilation protocols, changes in the patient's anatomy and time of procedure. And there's a lot of issues associated with this. But one thing that I think is really powerful and something that's really changing the way it's done is real-time intraoperative imaging that allows us to be able to visualize the lung nodule. Dr. Fabien Maldonado, who I'm going to hand over the mic to in a moment, has done a lot of work and studied this very closely in a landmark paper talking about fluoroscopic navigation technology. So I'll hand it over to you, Dr. Maldonado, and let you take over.
Okay, thank you, Krish. I hope everybody can hear me all right. It's a pleasure to be here. I want to thank the Medtronic team for inviting me. And so I'll talk a little bit about what our experience has been with fluoroscopic navigation in particular. I'll go over what I think the challenges and opportunities are. A lot of these have been touched on by Krish already. Let's see if I can advance the slides here. Go back to my disclosures. The most relevant disclosure I have is I'm being paid right now to talk to you about this stuff. So with that caveat, the rest is relatively irrelevant. I'll show you some of our things that we do in our lab, but just to make a few points. And we've got a study, upcoming study, that is investigator-initiated, but industry-funded. I'll talk a little bit about that. So why is bronchoscopy an important part of the pulmonologist's armamentarium? That's a complicated word, but CTNA works great. I was at a different institution for 10 years before I joined Vanderbilt, and all we did was CTNA for peripheral lung nodules, and if they were suspicious enough, we'd go straight to surgery or just repeat a scan if the pretest probability was low. CTNA seems to be a pretty good tool. The pooled sensitivity across many studies that were looked at in a meta-analysis published in Lung Cancer Guidelines back in 2013 is above 90%, and that's really what you get in most studies that have been looking at CTNA. As usual, the devil is in the details. If you look at smaller lung nodules, that sensitivity may go down a little bit, but it's highly variable across centers, obviously, and it's certainly old data at this point. Interestingly, we don't have great prospective data on CTNA, CT-guided biopsy in general. Certainly don't have any comparative data, which is an important point to emphasize. The downsides that are usually mentioned about CTNA is the rate of complications, and so we like to say as bronchoscopies that we cause less damage, quote unquote, we cause less pneumothorax and less hemorrhage. But the reality is that pneumothoraxes with CTNA are frequent but not often clinically significant. They're easily handled. And so I'm not sure that's the main selling point for bronchoscopy. I think what sells bronchoscopy is that we really can target multiple lesions at once. So it's not uncommon that we biopsy 2 or 3 lesions during the same bronchoscopy. And certainly more importantly, we can stage the mediastinum with EBUS, which is something that cannot be done with CTNA. Bronchoscopy, however, has been notoriously unreliable in establishing diagnosis, and certainly conventional bronchoscopy in particular is flip of a coin type of utility. The rate of complications is less, the diagnostic yield is awful unless you use some adjunct technique. Obviously, some cases are going to be more amenable to bronchoscopy. You get a 15-centimeter central mass, that's easy, but we're talking about peripheral lung lesions here. The overall yield of quote-unquote guided bronchoscopy, this would include not just electromagnetic navigation, but radial ultrasound-assisted bronchoscopy and virtual bronchoscopy. The number that's quoted most of the time is from this study from Jessica Wong-Memoli that she did with George Silvestri with a diagnostic yield around 70%. Now, what's interesting is that you look at the confidence intervals here. You get it's pretty wide, and as you look at where the data is coming from, you realize that they're coming from very experienced centers with a lot of expertise. So that may not be generalizable to all comers. Interestingly, this data was updated, and there's an abstract that was published at ACCP last year showing that rate is probably inflated a little bit. probably over-optimistic, and maybe it's closer to 60 to 65%, which means it's not great compared to the 90% we talked about for TTNA. Now, some studies, and just to point out again the incredible variability of the data that we have, and I would say that the variability in the data is primarily based on how you get the data. So, and what your definitions are. So if you define a diagnostic yield by, you biopsy, you find cancer there, or you biopsy and you don't find cancer, but you get negative follow-up. That's very different than the diagnostic yield, which is, do you actually have material on the biopsy that could explain the presence of a nodule there? So you have to be very careful when you compare studies that you're not comparing apples to oranges, and be careful about how the diagnostic yield is defined. So for instance, in the Acquire registry, we've got diagnostic yield for electromagnetic navigation that's about 40%, which is horrendous. The question is, how are these cases selected? Are these cases only happening when conventional bronchoscopy is not possible or too difficult, and then the most difficult cases trickle down to electromagnetic navigation? A lot of selection bias here. Navigate study is the largest prospective study that we have. I saw Eric on the call, Eric Falk, who was the PI on this large prospective study looking at electromagnetic navigation, and the 12-month yield was 73%, so better than the Acquire database, but clearly it's not yet anywhere close to the 90% we're talking about with TTNA. So there's a lot of new technologies that have been proposed in the past 5-10 years that have essentially looked at how to improve the navigation to the nodule. And so there's shape sensing technology, there's virtual bronchoscopy, electromagnetic navigation, algorithms that try to determine where exactly we stand in the airway, and radial ultrasound, and so on. The only issue with that is what Krish already mentioned, is that really the problem that we have when we do navigation bronchoscopy with most of these technologies is that we have a very different bronchial tree and lung space that we had when the patient underwent the planning CT scan. So we had a patient who took a big inspiration, full total lung capacity, and then all of a sudden we have a patient who was anesthetized on the operating room table, sometimes paralyzed with a breathing tube, and so things changed quite dramatically. And it's really this adjustment between your planning CT and your procedure that becomes an issue. I just want to show this slide from our lab here at Vanderbilt. This is pretty cool technology with steerable needles that Bob Webster has been working on for years. But this is electromagnetic navigation guided steerable needle biopsy. And I just want to point out that this target that you see here is hit with a remarkable degree of accuracy. This is all electromagnetic navigation. This is also possible in a moving target as long as you know exactly where the target is going to go. This is what you have in this little drawing here. The point I'm making here is that electromagnetic navigation is extremely accurate. You really can hit a fly on the wall across the room. The problem is that you don't really know where the fly is located anymore when you are relying on a preoperative CT, and that's really what the problem has been. And you've already seen this slide. Krish already showed it to you, that divergence, which is really related to respiratory motion. There's a difference between your planning CT and your lung volume during the procedure is an issue, not only in the lower lobes, where obviously diaphragmatic motion is going to emphasize and amplify that, but also in the upper lobes as well. There's a variety of other reasons why we may not be able to, biopsy the lesion that we've navigated successfully to, that have perhaps less to do with divergence, but I think this is by and large the main issue. And again, the same slide that we've already seen, just pointing out the difference between a pre-procedural CT scan obtained at total lung capacity with the patient fully awake and asked to take the deepest possible breath for a couple of seconds versus where the lung volumes are really going to cycle around during the procedure, which is completely different. It's obvious that you're going to get in trouble here. And trying to improve the accuracy of the navigation based on the pre-op CT, no matter how accurate you get, is not going to get you there if you're going to the wrong destination. And this is obviously going to be prominently displayed in the periphery of the lung, where you get the more CT to body divergence. This is precisely where we want to go with this peripheral lung nodule. Okay, so there's really not a ton of ways to visualize the peripheral lung. We talked about radial ultrasound very briefly. The problem with radial ultrasound is that if you see the lesion, you've already successfully navigated there. So it's a great confirmation tool. It's not that great of a guiding tool. And so the same can be said of cone beam CT and to a certain degree of digital tomosynthesis, which is the fluoroscopic navigation technology I'm going to mention here, uncoupled with some readjustment by electromagnetic navigation. I'll go into details as to what exactly I mean by that. We've been doing a lot of cone beam CT here at Vandy. We actually stopped during the COVID pandemic. But really, we're using cone beam as a confirmation tool. I know Krish and some people have a lot of experience with it. I'm still having a little bit of a hard time understanding how to readjust my trajectory to get my biopsies. And obviously, cone beam CT is not usually accessible for a lot of folks. So we get 1 half day a week of cone beam CT for 3 interventional pulmonologists here at Vanderbilt. And this is pretty much what's happening across the country at large tertiary centers, except for a few lucky ones among us. So this fluoroscopic navigation is really trying to replicate what we get with cone beam CT using what you already have in your procedure room, which is a conventional fluoroscopy arm. And essentially what we're going to do during the case is rotate this C-arm around the patient about 50 degrees to get a digital tomosynthesis. So what that does is that it really reveals fluoroscopically invisible lesions, making them more amenable to biopsy. And I just want to show you the type of images we get. So here's a cystic lesion from a patient we biopsied two years ago or so. And you can see on the fluoroscopy image, it's really hard to see what's going on here. With a little bit of hindsight, you can say, okay, I can see it there. But I'm going to show you what the digital tomosynthesis technology can do. So this is a coronal CT view. This is a CAT scan view, and I'm going to start the video, and I'm going to alternate between fluoroscopic navigation or the digital tomosynthesis and the coronal view here. Or not. Let's see. It's not working for whatever reason. So I saw the arrow for a second, but let me try that one more time. Here we go. So here's the digital tomosynthesis. It went pretty quickly here. I'll just stop here because it's going to drive me nuts. But you can see, for instance, here with a subsolid opacity, so mixed solid and subsolid and ground glass opacity. Here's a coronal CT view. You can see the lesion pretty well. And here's the corresponding digital tomosynthesis image. You can see the vasculature is also pretty similar to what you have with your coronal CT view. And that's been kind of the rule that we've seen, these lesions fairly successfully with digital tomosynthesis. The main issue with this is that, similarly to what Krish was saying about cone beam CT, if you're not careful about your ventilation strategy, your PEEP level, you will get some atelectasis and it will become difficult to see. And this is obviously going to be more likely to happen in the lower lung zones, near the diaphragm, and near the mediastinum as well. Here's a pure ground glass opacity right here. Not sure whether we're going to be able to see it, and you can see the corresponding image here on the digital tomosynthesis. All right. So with regards to trial and error, when we started these using fluoroscopic navigation, we got into a lot of issues with atelectasis and lesions that were initially visible that over the course of the procedure became completely drowned into a lot of atelectasis. So we've learned from people working with cone beam CT that really there are useful strategies to try to mitigate this problem. You know, we intubate everybody to maintain relatively high level of PEEP in the lungs. I know that's not been the absolute rule for everybody, but we use general anesthesia and muscle relaxation on everybody. We typically do a recruiting maneuver before the bronchoscopy, which varies, and then put the patient on at least 10 or 15 of PEEP, a little bit more in overweight patients. You know, I know there's always a little bit of reluctance in doing this because of the concern for pneumothorax. We really haven't seen that as a big problem, and our rate of pneumothorax before and after introduction of digital tomosynthesis and cone beam CT really have been exactly the same. We also limit the FiO2 to avoid absorption atelectasis. So if you're on 100% FiO2, you're going to empty out some areas of your lung, which if they happen to be in the area of your nodule, you're going to get yourself in trouble. During the sweep, so during the movement of the C-arm around the patient, you really want to have a breath hold there, and you want a breath hold that's maintained at about 20 of PEEP. And so you need to communicate with your anesthesiologist. And you know, we had a lot of back and forth initially to try to find the right strategy. APL at 20 during the sweep seems to be the best case scenario. We've really integrated this technology into our practice, and doing, you know, fluoroscopic navigation now is really a natural thing that we really don't think twice about, and most of our CRNA are very comfortable with the procedure. Now, I put that you need 2 operators. That's probably true. If you're doing navigation bronchoscopy on your own, it becomes a bit overwhelming, especially if you don't have a bronchoscope holder. And if you don't have a bronchoscope holder, try to figure out how to make one or find one in the OR, because that really changes your life. The ability to have your scope fixed and just having to worry about the edge catheter is really, really great. And just obviously review all cases with whoever is helping you out, and learn from your failed cases. That's really important. So here's our initial data that we published last year, and this really was not at all a landmark paper, as Krish mentioned. I think it's a very small and preliminary study that is interesting nonetheless. So if you look at what we compared, we have standard bronchoscopy with ENB, so electromagnetic navigation bronchoscopy, for 4 months before introduction of the fluoroscopic navigation, and then we looked at cases 4 months after. So you have 4 months of standard ENB, 101 nodules, and then 67 nodules in the 4 months after introduction. Now, there's a little less nodules in the second phase, primarily because we had 2 towers at that point, one that could accommodate fluoroscopic navigation and the other that couldn't. And so we only looked at the cases where fluoroscopic navigation technology was available. But you look at the size of these nodules, these were tiny nodules, talking about 15 millimeter, 16 millimeter nodules, same size before and after. Majority of them, 60 to 65%, were less than 2 centimeters. And if you look here on the right side of the bronchosine was only present in about 37% before introduction of fluoroscopic navigation and 22% after. So by and large, these were nodules that did not have an airway leading right into the nodule. Now, what we talked about here is the yield, the diagnostic yield, and really we're talking about the diagnostic adequacy of the sample. Did we have on the biopsy evidence of cancer or something else that could, in a compelling way, explain the presence of a nodule there? In other words, we find granulomatous inflammation or pus or something that is like a hamartoma, something that's obviously diagnostic. And so our diagnostic, and I'm not talking about follow-up here, I'm just talking about what we got that day on the biopsy. So we went from 54%, 55% to 79%, which was remarkable for us, and clearly a technology that has really changed, I think, the way we practice. Now, we looked at more data over a year, and then we looked at 6 months follow-up and that's an abstract that was published in Chest, and we get about the same results, so confirming what we had. Get to the next slide here. Okay, I just want to spend a little bit of time talking about, let's see, am I taking all the time? Okay, I'm almost done. About how we define diagnostic yield, because I think that's a really crucial question that really hasn't been addressed in a satisfactory way. And I think we're at a point in our interventional pulmonology specialty trajectory where this needs to be standardized in a formal way. The reason why I mention this is because, you know, if we're comparing apples and oranges, I mean, there's new technologies coming on the market, and you get robotic bronchoscopy, and you get this and that, and Medtronic, and so on. And everybody's doing their studies in a slightly different way that makes it very difficult for the objective observer to know which is best. And I think part of the problem is that we don't have good definitions of diagnostic yield. So the traditional definition of the yield for bronchoscopy has been, if you find cancer, you count this as a win for bronchoscopy. If you find anything but cancer, and 6 months or 1 year or 2 years down the road, you don't have any evidence of cancer, then you count this as a win as well. And this is a really, you know, intuitively interesting but completely wrong way to look at this. Here's an example. If you have a population of nodules, let's say you get 1,000 nodules, 10% of them are malignant. That's the ground truth of that population, and 90% of them are benign. And you're the most terrible bronchoscopist in the universe, and you biopsy the heart every single time. If you look at your follow-up, you get myocardial tissue, but you don't have cancer at 1 year or 2 years, you're going to count that as a 90% yield. And obviously, it's immediately obvious that this is the wrong way to look at diagnostic yield in bronchoscopy. If you look at the bronchoscopy studies that have been published, unfortunately, that's often how we define diagnostic yield. So you need to be mindful of that. If you're going to use this definition of diagnostic yield and make sure that the other study is using the same definition, and in my view, it's a terrible definition, but at least make sure that everybody's talking with the same language here. So I think really the way to look at the yield is, do you have lesional tissue, and by that I mean you have cancer, granulomatous inflammation, hamartoma, something that's definitive, and you don't have any evidence of malignancy on follow-up, because you can have a little bit of granulomatous inflammation in the vicinity of cancer. That's certainly possible. So anyway, that's kind of a pet peeve, and I just wanted to point that out. And you know, I don't need to go into a whole lot of data, but if you look at the recent studies, whether it's robotic-assisted bronchoscopy, and I'm not going to hammer anybody here, or Navigate study, and you look at the underlying assumptions there, you will realize that we really have to be careful what we're talking about. Okay, in our you know, studies that we're doing, we're using a definition of diagnostic yield that would really look at all these benign, non-specific, inconclusive normal lung tissue as missed for bronchoscopy. And I think that as a community, that's where we probably need to go. All right, already seen this slide. I'm just going to finish, and I'm not taking all of Mark's time here, so I'm going to finish quickly here to introduce the study that we just literally opened. So we were on hold after opening it at Vanderbilt because of COVID, and we just got the green light from the Cancer Center to restart. So this is the Veritas study. This is a randomized control study that we are starting, comparing navigation bronchoscopy with digital tomosynthesis adjustments, so fluoroscopic navigation to transthoracic needle aspiration. Now, we're not aiming to show that we're better than TTNA. I think that's a tough standard to beat, but we'd like to show that we're not far from it and equivalent. And the rationale here is that, you know, showing that we're equivalent with a procedure that can, in addition, give you the mediastinal staging that you will probably need to do afterwards, plus gives you the opportunity to biopsy multiple lesions at once, may be something that's relevant to our practice. It's a one-to-one randomized control study. We're about to enroll the first patient, hopefully this coming week. It's a non-inferiority study design. In other words, we're trying to show that we're not far from bronchoscopy. We have anywhere from 6 to 8 sites. So in addition, including Vanderbilt, depending on how enrollment will go, and our target enrollment is 258 patients. We're looking at not just intermediate pretest probability of malignancy, we've changed that. We're looking at intermediate and high pretest probability with nodules of size between 10 and 30 millimeters of lung diameter, located in the mid or peripheral third of the lung. And all these cases are going to be adjudicated by a panel ahead of time with an independent interventional pulmonologist and independent interventional radiologist to determine whether these nodules are amenable to either or procedure. And we're going to minimize the randomization, that means stratify the randomization based on the location of the nodule and the size of the nodule as well. The primary endpoint will be diagnostic yield, and I've kind of hammered that point already at length. But essentially, we have a definitive diagnosis on histopathology and absence of malignancy at 1 year. This is the algorithm for the study. So kind of standard cTNA for interventional radiology, and a little bit more of a detailed algorithm for bronchoscopy with fluoroscopic navigation, just because we need to make sure everybody's standardized and doing the same thing. And that's it. I'll stop here, and I guess we'll have time for questions at the end. I will let Mark take the rest of the time at this point. Thank you.
Okay. Hello, everybody. I hope everyone can hear me okay. Extremely honored to have the opportunity to talk to you today. I really want to thank Medtronic for giving me this opportunity, as well as specifically having the opportunity to serve on this panel with such great pulmonologists. Can you guys hear me okay?
Yep, we can hear you, Mark, and you should have control. So is your mouse moving? If not, I can assist the slides.
Yeah, it's not moving. I've been trying to advance it here.
Okay, let me take over.
Okay. The first couple slides are actually going to be prepared by Medtronic, which I appreciate. And this is the new device, a new tool called the Illumicite, which is simply pretty put together. It's the standard Super D, but they've added fluoroscopic navigational technology, so we're able to actually correct for the CT body divergence, and also added a continuous guidance tool, which basically means that once you get to the target and you correct it with local registration with fluoroscopic navigation, you redirect to the target after it's been corrected. And then when you take the LG out, you continue to have basically a navigational tool. Next slide. This is, again, I'm not going to go over this because we just talked about the fluoroscopic navigational technology. We talked to Maldo, talked about very well. And this is continuous guidance. This is what I meant. This has been one of the issues, I think, with navigation for a while, is that once you take the LG out, you're kind of left with just the fluoroscopic image. And as you place tools, it can certainly straighten out the catheter and can have you thrown off. So this is a nice feature to where you're always able to see the green ball. Now remember, this is the green ball after it's been corrected if it needs corrected. Next slide. So the best thing to do is just to show a series of videos. These are the cases that we've done. And all of our patients actually get their mediastinum staged with EVIS, as well as if there's malignancy at the bedside, we go ahead and place fiducials. You can go ahead and start the video, hopefully. This is just the basic registration process. I know you're all very familiar with that. You do the basic registration, which you're used to going through. And then you navigate as you normally would. Once you get within a couple of centimeters from the target, you'll be able to launch the local registration, which you see up there. This is just basically reminding you what you need to do. You'll need to position the forearm appropriately. And once you do that, you want to put the LG right in the middle of that circle there. And now we're getting ready to do the sweep. You do a breath hold, usually at tidal volume, and then you're going to sweep basically from 25 degrees positive to 25 degrees negative, about a 8 to 12, sometimes a 15-second sweep, very smooth. And then this is where you're going to get the tomosynthesis. Next step is once the computer goes in and starts jumbling up the software, you're going to tell the computer where the tip of the LG is, and that's exactly what you're doing there. And then the next step is you're going to tell the computer, based on this tomosynthesis view, where the target lesion is. And you get some really nice images. Now you're going to say this is the target lesion in 2 extreme positions from LAO to RAO. And then you can see the crosshairs there as well as the circle, and as it moves from LAO to RAO, and it's just telling you that the catheter tip looks like it's pretty much right on that. Now this says that the navigation catheter was correct. It looks like we were right on it right before. If it's not, you can re-navigate to the area. Now you're ready to go ahead and start biopsying. So actually, all you have is the EWC. There's a bunch of very nice slides. You can pause. I don't know if you can pause right here for a second. So just to point out a couple of things, the different screens you can have, I found very, very interesting. They're really cool. So you can do a lot of different things here. We actually can have the fluoroscopic image now on the EMB screen, as well as what other kind of fancy endoscopy suites that you might have. You can go ahead and start it again now. But you can see over here, this is actually your local control here, and this is just an image where you can actually see the green ball as you sample, and then you got your fluoroscopic image. And I think you're going to see right here we're actually putting in a fiducial at the end. We usually place 3 more fiducials, a total of 5. Okay, next slide, I think. So that's the overview of the procedure. Is this the same one again? I think so. There you go. This is please forgive the video on this. This is just my cell phone. We have a very humble bronchoscopy suite, but this is showing you this is the difference between the standard Super D, and this is a 7.1. You can go ahead and start the video. So this is what it looks like when you take the LG out. You basically have nothing but the fluoroscopy over here, and you start sampling. Now this is the difference with the Lumicide. As you can see, you actually can see the target, you can see the fluoroscopy, and you can actually see the needle, the image actually going up and down as you agitate with a needle. Next slide. For some reason it repeats. Yeah, there you go. This is a case that we did. This guy with ENT cancer had bilateral, very small lesions. We went through and used a Lumicide with this, and you can actually see a rebus image here. You see a very small lesion. You can see the fluoroscopic image. Went in and got samples on both these images and got malignancy on both at the bedside. Fortunately, no complications. So really nice images you can get out of this system. The other thing to note that you can manipulate the catheter. So when you're in the continuous guidance mode, what I really love about the system is that as you start to biopsy, you can twist and turn the EWC to keep that target online. And that's what's the most cool about it. You kind of know where you're at all the time, and you put that with a fluoroscopy, and it's really a deadly situation. And I don't mean that as a pun. Next slide. You have to hit it again. I don't know why it repeats. Okay, this is just another one that's showing this guy had multiple lung nodules. The thing that's really cool about this one is this lesion right here. And you can see that this is a tomosynthesis image after we did a sweep. And this is the actual video. Now, the video is really hard. Can you pause this? What I kind of wanted to point out in this one, and again, I apologize for the quality of the video. is that we actually didn't have an airway going to this particular lesion. And what we wound up doing was using the arc point needle with the guide wire, and with this continuous guidance, kind of did a mini cross country. We were able to kind of make a tract and use the guide wire and make a hole outside the airway, and then use the continuous guidance kind of cylindringered over the needle into the actual lesion, and then we're able to get samples and was able to get a diagnosis of this. And this is actually a really cool case. Next, you can hit unpause now. Next slide. One of the things I really like about this is the central navigation. You can pause right here for a second. As far as what I'm concerned, and we can go and play it back in a second, is that, let's see if it's the same one. No, I think you might have to go back. Maybe not. Go forward. Wait and play, yeah. All right, pause it right there. So, it's okay.
I'm sorry, it won't pause.
That's okay. In this hilar area here, I find it really difficult. You can't get an EVIS up there. It's really too close in to use navigation necessarily with the EWC. And I personally have struggled a lot in these, almost going right up in the upper lobe in the hilar area, trying to get samples by using the central screen and access with E&B, which usually was used with lymph nodes, and obviously this probably is a lymph node. But man, really makes a difference with this continuous guidance. And what I basically did was a standard TBNA, but used the continuous guidance to be able to get this kind of hilar lesion. And I fell in love with it. It really makes a big difference. I've struggled for a long time with these type of lesions, and it was nice to be able to use this tool. Next slide. But this is just the central view. Let's see what this one is. I can't remember. Oh, yeah. This is a lady basically had a lot of fibrosis in this upper lung. They wanted me to go ahead and biopsy it. It was PET positive. We got up there and got dead on it, which you'll see in a minute with a tomosynthesis. We got a fairly decent Rebus image as well. We went up and biopsied it, and it came back just a lot of acute inflammation. As noted, that's not a diagnosis, but she's been followed for several months and it hasn't changed, so we're just going to keep following it for right now. Next slide. This is another case with a woman that had renal transplant, immunosuppressed, who came in, and we basically went up and wound up biopsying this, and it wound up being nocardia. Thought for sure it's going to be cancer, but again, you can kind of see just really nice images. And this is actually forceps biopsies here.
Mark, can I ask you a quick question about these cases that you're showing? These are fantastic images. One of the things that you kind of mentioned, you've alluded to this, is the ability to be able to manipulate the catheter with continuous guidance. One of the things that I feel a little bit cautious about, especially with, I have currently the Flora nav system, but with the Lumicide, it sounds like you're going to be able to do multi-directional sampling, and you're going to be able to go after the medial aspect, the posterior aspect, and you're going to be able to target your biopsies. Have you noticed that that's been helpful for you in particular, and utilizing that it was an alignment view, or I would probably describe it like a bullseye view?
Yeah, we found it. We've only done about 80 cases, so I can only speak to about that much. But and we're still learning quite a bit from it. But yes is the answer. You can continuously kind of torque this catheter as you move forward to get different directions and different angles into the lesion. I've actually very much impressed with this system. And as well as being able to place fiducials in a little bit better accuracy, at least I think, or I'm getting some good feedback from our radiation oncologist, as well as using it in a sense with cross-country or cross-country-like maneuvers. I've been very impressed with. So the short answer is yes.
Yeah, I think you're quite humble. I mean, you've done 80 cases with Lumicite, which basically puts you're the first in the world to do this, and we're looking to you and kind of trying to put together what this means as this rolls out. I think there's over 100 sites that are going to be able to get a Lumicite. What are the other advantages that you've seen throughout these cases with the continuous guidance, the multidirectional sampling? Is there any major differences between this platform and the FluoroNav platform?
Yeah. What I could probably say with that, obviously the continuous guidance, when it comes to the fluoroscopic navigation technology, with the Lumicite, and the folks who understand the technical aspect can explain it better than me, but from the practical, just guy sitting at the bedside, it's much faster. You're not doing a whole lot of waiting, and with the continuous guidance, you're not always checking, putting the LG back in, putting the rebus back in. And if you do the rebus, you can actually put the rebus in and then push the catheter forward and manipulate the catheter just like you would with your tools to find the right angle. So actually, even though I haven't timed it, again, please, this is all anecdotal. It's just one person's experience. But it does seem to be faster and smoother. And I have to admit, I'm going after lesions that I never thought I would be able to go after. When I have tried before, I've been unsuccessful and been very pleasantly surprised that we're actually getting lesions I never thought we would.
That's fantastic. Sorry to interrupt. I'll let you continue.
No problem. Next slide, please. This is a really cool case. I got super excited about this case. This is a patient, left lower lobe, obviously needed to go in and biopsy. We got in an area that you'll see right here, right on the edge. And I don't know if you can pause that. Oh, shoot, sorry. See if we can get to it one more time and I'll show you. Okay, right here, and I don't know if you can see my mouse, but right on that edge there, that's okay, where it says 1.1 in the bullseye view, that was actually going right along what I interpreted to be the chest wall. And I thought for sure I was going to get a pneumothorax on this, but boy, I tell you, using that continuous guidance, we nailed right into it. We were able to see it with our rebus in the same direction and got a great diagnosis with it with no pneumothorax. So I think this thing's pretty doggone accurate. And again, very impressed with it. Next slide, please. Just a reminder, we're just now starting to use the cross-country, or at least we were starting to use it a little bit more, particularly with this device. And just to remind you that I think this is going to come back into vogue really strongly with this tool. Next slide. This is an oldie but a goodie, but just to remind you of the cross-country, this is one that actually one of my colleagues and I did way back in the day when cross-country first came out. This is not with a Lumicite. This is just some really great images to kind of show you how we've used cross-country before. And I think when you have this along with the continuous guidance and the fluoroscopic technology, it's going to be really, really neat. But this is a right upper lobe lesion, a patient who had colon cancer. You're going to see us try to get to it in a minute. We're not going to be able to get to it. We're going to bounce off the target here. You can fast forward it a little bit if you want there. Save room for questions. Oh, if it doesn't work, that's okay. Yeah, see if you can click it a little bit. Yeah, so we did a cone beam on this. Go back just a little bit more. Sorry. That's okay. Yeah. That's just us biopsying after we did the cross-country. Come on back about halfway. A little bit more. Back some more. Come on back. Right about there, right there. Okay. So right there is good. So basically we're trying to get to it right here. Oh, that's okay. That's all right. Don't worry about it. It'll catch there in a minute. For those of you who don't know him, this is Carlos Anciano's video skills. I keep telling him I think he's going to try to win a Grammy or some kind of award with this stuff. He does all this fancy stuff with it, but they are rather long.
You're getting pretty fancy on social media.
Yeah. Yeah, I'm a little embarrassed by that, but this is us trying to get back to the EMB. This is with this, actually the version 7 system. You're going to see us bounce off this. We're not going to be able to get to it. Again, this is metastatic disease, probably hematogenous spread, doesn't have an airway going to it. So now what we're going to do is we're going to flip out, and this is some great way they were able to split the screen. We're using the cross country here. You're going to see, it's a little hard to see, but you're going to see the guide wire come out. And then we're going to put the dilator in, and you have to push on these things pretty hard. You see how that really kind of buckles up? You got to put a lot of pressure on it. You're going to Sellendinger over the dilator, and then you see us go right into the lesion there. So we're going to go and actually we did these first initial studies with cone beam. I actually don't use cone beam at all anymore. But we did a cone beam spin just to kind of prove that we were in the lesion. Of course, this is a bigger lesion. You know, these guys like Bhadra and Pritchett, Dr. Maldonado, they go after these really, really small lesions with this. I don't have those skills. But you can see actually the EWC is actually right into the lesion here. And you can go ahead and fast forward now and just go to the next slide. But basically, we did some biopsying. This is our first initial data. This is actually, I think, only with 60 patients. I've looked at the rest of the data now. We've done 80, but I've only got data up to 74. But this is with 60 patients, and it kind of showed that 77% of our patients' lesions turned out to be malignant. 6% were non-malignant, and then 17% were resolving or non-malignant. That 6% was actually supposed to be a non-diagnostic. Next. And this is just showing you our diagnosis of, we had 56 patients we diagnosed, 4 were non-diagnostic, and then our diagnostic yield, which when I say 56, we actually knew exactly what they were 93%. It actually now, we're up to 74 patients. It's dropped to around 92%. And then all of our non-specific diagnoses, the CT scans up to date have cleared, or either we got an actual diagnosis. Next slide, please. And this is just kind of playing off what Dr. Maldonado's group has done, a really, really neat study. It's just kind of showing how it affected our diagnostic yield. Our data, and you got to be a little bit careful with this data now. We've been doing navigation for a while. But we put together a database, and up to about a year ago, I was keeping it up to date, and to be honest, I stopped. But up until that point, our diagnostic yield was right around 87%. And then you can see with the Lumicide, it went up to 93%. Next slide, please. And that's just really basically it for me, and I can take questions or turn it back over to you.
That's great. I was actually curious. Can you hear me?
Yes.
Yes.
Yeah. I was curious about the cross-country in conjunction with Lumicide, and I have not utilized cross-country outside of a lab. And Fabien, I don't know if you have either, but one of the things that I find kind of interesting is, you know, interventional radiology, they never worry about bronchus signs. They never worry about airways. I mean, there's always this perception with E&B that we're prisoners of the airway. And then one of my thoughts is not necessarily that we are, but rather we need to be able to have better alignment with the target. And obviously there's airways that are thick and difficult to burrow through and push back on the needle and cause deflection. But when utilizing your experience with cross-country in combination with the Lumicide and having that continuous guidance at the same time, I mean, one could propose that in theory, obviously, you know, further study would be indicated, but you could potentially bypass a lot of those issues. And I don't know if have you had the opportunity to utilize it with the Lumicide yet, or?
Yeah, I've done a couple of cases, and it's worked really great. It's still a fairly rigid tool, and that's always been one of the issues. But you do have the advantage now with the continuous guidance to kind of always see that target and then help change your position as you put the cross country out. I will admit, though, since the ARC point came out, I use that a lot, like across country, because a lot of the times I think we can get close enough that you can core a hole with that 18 gauge with a guide wire, at least from my experience, and get close enough that you can get in those lesions pretty well. You know, you guys don't need them because you're good enough. You don't need cross country. You're able to get to where you need to get to. But it is a tool that can be used, and I think it's going to get a lot of use, at least in my opinion, when everybody gets to Illumicide. I can't wait till it gets in the hands of a lot of folks out there are really good bronchoscopists and very creative, because I think they're going to see a lot of things very useful about it, and it's going to add a lot to all of our practices.
It's very insightful. Fabien, with your experience with Illumicide, I mean, you two guys are basically, you know, the experts on Illumicide as of right now, and I just wanted to kind of hear from you what your experience is with the Illumicide platform. What do you see as the obstacles? One of the things that I've kind of thought about a lot is, and it's been brought up by multiple people, is that the bed gets in the way, and if you don't have a radiolucent bed, and I don't know if you can speak to that, Fabien, and what your thoughts are with the platform. You might be on mute. I don't know if, yeah, you are on mute.
Okay, can you hear me now?
Yes.
Okay, good. I was going to say that the radiolucent bed is a non-issue in my view. We've been using fluoroscopic navigation for a while with a regular OR bed and try with, you know, the fancy bed, and I really haven't seen much of a difference. I would say, so we don't have the experience that Mark has with Illumicide, with the continuous guidance. I personally think the big step forward with this technology is the ability to recalibrate your navigation, see the lesion, and be able to correct your plan. You know, beyond that, I think it's great bonus stuff, but I think that's the major thing that has made my life much easier from occasionally becoming very frustrated with the technology to now really, you know, most of the time at least knowing that I get super close if I didn't get it. So, you know, again, I think fluoroscopic navigation is really the way to go. I would echo what Mark said about the cross country. You know, when you get to the periphery of the lung, you know, the lung is fairly flexible there, and with an angled catheter, really what you have to do is really align yourself with the lesion. And if you use the needle, which everybody should be using, then, you know, it's very easy to get out of this airway and biopsy a nodule that's not connected to one. If you look at our data, you know, we only had about a quarter or less than a quarter of nodules that were aligned with an airway with a bronchus sign. The vast majority don't have anything. So I think the cross-country tool is interesting. Granted, you know, there's some cherry picking here because, you know, we're in the clinic, we look at nodules, we see that there's zero airway anywhere close to the lesion. Chances are we're not going to do that case. But I would say that these are few and far between, and the vast majority of the time there's some airway out there that's close enough. So for the study, we said, you know, if there's an airway that's within 3 centimeters of the nodule, this is a good case for bronchoscopy because really we can align ourselves and deploy that needle. And what we're seeing is in many cases, you don't get a radial ultrasound view at all because you need a few alveoli, you know, filled with air to lose your radial vision. But once you've passed that needle into the nodule, you create a path that your radial probe can follow, and not uncommonly we'll see the nodule afterwards. So, right. So fluoroscopic navigation for me really is the game changer, to be honest with you.
Yeah, and I think, and I'm going to echo what you're really pointing out is probably the most important aspect, is that bronchoscopists in general, whether it's myself or anyone, or the two of you, is we're excellent at bronchoscopy when we actually know where the target is, or it's fluoroscopically visible or visible by fluoronav or Illumicide. And there's going to be this movement to correct for the CT to body divergence and real-time intraoperative imaging. And there's really not a whole lot of systems that are available to us. And so this is the first type of product or products with both FluoroNav and Illumisite that really allow us to be able to visualize these lung lesions and drive to it. On that note, I wanted to thank Medtronic for allowing me to be able to be the moderator for this talk, and I'm going to turn it over to Jody and hand it off to you.
Wonderful. Thank you so much, and really appreciate all three of you for your outstanding presentation this evening. I know it was really insightful, and appreciate you taking the time to participate and to share your experiences, your videos, your papers, and your great knowledge in this space. So Dr. Bhadra, thank you for hosting, and Dr. Bowling and Dr. Maldonado, thank you again for your time tonight. And audience, I would just ask, if you wouldn't mind, we would love just some survey results back. You can take your camera and aim it right there at the QR code on the screen, and it will pop up onto your phone with a few questions. And as I mentioned at the start of the call here, we will be doing these WebExes monthly, so look forward to providing you invites and having you join us. So thank you, everybody. Have a wonderful evening. We'll be in touch.
Thank you,
Good night.
Judy.
Thank you.
Bye-bye.
Bye-bye.